Hello, everybody. Welcome to this very special Risky Business Forum on navigating a shifting healthcare landscape. My name is Dr. Peter Lawson from Boston Children's Hospital, and I'm here with my co-host, Barbara Fain from the Betsy Lehman Center for Patient Safety. It's certainly been a challenging 15 months for so many of us across the world as we've managed through this pandemic. We first want to thank you for all of your efforts that have been tireless over this period of time. We are heartened to have so many of you join us today from across Massachusetts, the US, the UK, and beyond. And our hope is that today's program will inspire new thinking about how we can draw on the knowledge and experiences from other complex and high-risk organizations and professions to achieve safety in healthcare. Barbara.
I too want to welcome you and also to thank Peter for championing risky business over the years and for proposing this collaboration to bring it back to Boston. Of course, as it turns out, most of us are not actually in Boston today, but our virtual format means that more of you have been able to join us, which is great. So coming up, we have an outstanding group of speakers led by two skilled moderators who are going to take us through a series of rapid fire presentations and questions from you, the audience. Our first group of speakers will look back at the past year and share ways that they managed through the pandemic in their own work and lives. And then our next speakers will take a look ahead towards strategies that we can use to emerge stronger from all we've experienced in the last year. As I mentioned, there will be opportunities for you to ask questions. So please feel free to use the Zoom chat function and send a chat to all panelists at any point during the program to address this question to any of our speakers. We'll also be live tweeting using the hashtag RiskyBiz21. So feel free to join us on Twitter.
Thanks, Barbara. Today's program was shaped by a coalition of Massachusetts-based organizations very invested and very skilled in aspects of patient safety. And you can see those societies and organizations listed here, and we thank them for their insights and assistance in organizing this webinar. We also wish to thank two of our key sponsors, Idiometry and the Hospital for Sick Children in Toronto. And now I'd like to introduce Dr. Kevin Churchwell, Chief Executive Officer of Boston Children's Hospital, who will share his thoughts in opening remarks. Thank you, Kevin.
Well, thank you, Peter, and thank you for, Barbara, thank you for the opportunity to be part of this incredible and important conversation. When Peter and I were talking, he mentioned that the first topic that I would be part of was managing through crisis. And the question was, did I have some comments around that? Keeping it to just 3 to 5 minutes. So that's my goal in thinking about that. When Peter brought this subject up, I started thinking about crisis in healthcare during the pandemic. We don't come to work every day thinking about that we're going to manage a pandemic that happens once in a millennium. But that's what has occurred. And it's given us the opportunity to think through how do we actually work in our organizations, especially in healthcare. Because as you realize, as you know, the healthcare industry, the hospitals have been the fulcrum that has truly, I believe, in this country, supported our management through this crisis. Without the healthcare, the hospitals doing their job, I think we would have been in significantly tougher shape from that standpoint. So just a few points or thoughts around managing through a crisis that I'm sure we'll talk more about. These hospitals that we work in, the hospital that I work in, we talk about it in many respects like working on a Queen Mary. And the question is, how do you turn a Queen Mary quickly? How do you make a Queen Mary go from that to a speedboat? Well, I think there are a few points. One is decision-making. How have we changed the way we make decisions? We've done it by getting data, but not being wedded and stopped by the data. and not being overwhelmed by them to make decisions. And then we've made decisions. But in those decisions, I think importantly, we've attempted to simplify them. You know, Henry David Thoreau said, simplify, simplify, simplify. And I think that's really important. At Boston Children's, we surrounded our decisions based upon three principles: safety, safety, safety. Safety for our patients, safety for our families, and safety for our staff. And all of our decisions have really rotated and been involved around those three issues of safety. And with that, we've been able to stay consistent. And then the third point is around communication, and that many of us in the healthcare felt we were communicating. And I will tell you, there's a difference in communicating and truly communicating. And we, in this crisis, have really worked and developed our ability to communicate on a regular basis, transparently, and providing every opportunity to let everyone know what is happening, what we are doing, what we need them to do. And finally, I would go to the issues around trust. And that trust has been incredibly paramount, because what we've done is ask individuals to do incredibly difficult things. And in order for that to happen, you have to have trust. And you get trust by actually what I talked about in the first three opportunities, from the standpoint of communication, simplifying, and making decisions. I don't really know what's going to happen moving forward after the pandemic, especially with those that have been on the front line. How has our trust affected them? So I'll just tell you a story. At the end of World War II, Dwight Eisenhower had to make some significant, important, very difficult decisions. D-Day, what to do there, the Battle of the Bulge, as two examples. In that, he exposed an incredibly large number of American soldiers to harm's way. And he knew that. He knew that many of them were going to die. Prior to sending them out, he visited with them, and he told them what they were doing. He told and thanked them. So he developed a trust with the American soldier. About 1951, after the war, he was asked to speak at a veterans gathering. He was extremely nervous, very anxious about the talk, because he felt that he was going to be booed, because he had put these individuals in harm's way. And he felt that he was going to be totally put out from that standpoint. So he arrived at the meeting for his presentation, walks in the room, and receives a standing ovation and thank yous from his troops, from the troops, because they trusted. And I think that we should think about that and appreciate that as we move forward. Trust is incredibly important. I'll stop there and turn it back to Peter.
Kevin, thank you very much for those opening comments. So important around the way we communicate and develop trust. Now I'd like to introduce Rob Wiseman. Rob is a reporter for the Boston Globe, very experienced, who has been right in the thick of the newspaper's really exemplary coverage of COVID-19, including the vaccination efforts. Rob will guide us through the first half of our program today, Managing Through a Crisis. Thank you, Rob.
Thank you, Peter, and hi, everyone. Our first group of speakers bring unique perspectives of the past year from fields outside of healthcare. Lieutenant Colonel Sue Gannon brings years of command experience in the U.S. Army and Army Reserves, and also worked closely with Tufts Medical Center and Tufts University in responding to the pandemic in the earliest days. She will be followed by Liz Miranda, a representative to the Massachusetts legislature from the most diverse legislative district in Boston, who will share her story of COVID's impact on her family and community. After that, you'll hear from Josh McDaniels. Patriots fans will need no introduction to the New England Patriots offensive coordinator and quarterback coach, who was at the helm for 8 extraordinary Super Bowl runs. He will talk about how his team adjusted to the NFL's planning and decision-making throughout the pandemic. Josh was able to record his remarks for us on Tuesday and will join us for the Q&A immediately afterwards. Remember to add any questions you have for our first group of speakers into the chat, directing them to all panelists, and we will get to as many as we can during our discussion. First, let's hear from Sue.
Thanks, Rob. Before I begin, the Army's lawyers have asked me just to point out that the opinions and views I express here today are my own and not that of the U.S. Army or the U.S. government. Now, as a rule, I don't usually answer unknown phone numbers, but I'm glad I did on March 13th, 2020. That call led to a remarkable 4 months with the team at Tufts Medical Center, assisting in their COVID-19 response. To the team at Tufts, you're an inspiration, and it was truly an honor to work with you. Now, I'd like to start with a story, an Army story. And truthfully, they're better yet served in a bar with a raised glass together, but we are in the middle of a pandemic, so nonetheless. So no kidding, there I was. It was 2004 in Tikrit, Iraq, at a base located on the Tigris River. I was a 22-year-old second lieutenant with just over a year in the Army. My platoon and I were about 7 months into a deployment. That day I was walking from the headquarters to my platoon area, and in the distance I heard the telltale thump of an enemy mortar leaving its tube headed toward the base. Now, this was a common occurrence. It happened multiple times per day. And as I heard the round whistling through the air, I did exactly what I was not supposed to do. Instead of taking cover in the concrete bunker that was literally 20 feet away from me, I paused. Clouded by 7 months of 15-hour days and very little sleep, I carelessly assumed that it was highly unlikely the mortar was going to hit me, and I kept walking. That's right. Enemy rounds were in the air, headed toward my general location, and I kept walking. Thankfully, I was right. But in hindsight, I cringe at the disregard I had for my own life. I'm also grateful that none of my soldiers saw me do such an incredibly stupid thing. Had they been with me, I would have put them all at risk. This is my first memory of the impact of prolonged crisis on my ability to lead. Now, after nearly 18 years of military service, I'd like to think that I've grown and learned from that day. And during my time with Tufts, I was able to apply some of the lessons learned and experiences that I had leading in crisis. Now, as we know, hospitals are wired to deal with crisis. Life and death is part of their mission. However, unlike, say, a mass casualty event, which might be large in scope, but relatively short in duration, the COVID-19 pandemic has touched every single aspect of the hospital. And it's been exhausting for everyone, from the C-suite to the clinical staff to the support personnel. So how do we as leaders approach these challenges and lead our organizations to overcome them? While there are many things to consider, I am going to focus on two things: decision-making and people. When it comes to decision-making, there are 4 critical questions to ask. First, what are the critical decisions? 2, who makes those decisions? What information is needed to trigger those decisions? And where is that information being kept? With the Tufts Medical Center team, we took time to develop this critical high-level decision matrix. And this exercise was beneficial for multiple reasons. First, it aligned the members of the senior team as to what the critical decisions were, who was going to make them, and at what level. Prior to this exercise, we had discovered that many members of the team were planning based on invalid assumptions about what others in the organization knew or were doing. Second, it generated a list of critical information requirements. This list was distributed throughout the organization to guide leaders in filtering the large amounts of incoming information. In turn, it provided decision makers with the critical insights needed to make timely and accurate decisions. This sort of information triage is critical, especially in the early stages of a crisis, when you are trying to prioritize multiple competing efforts. And third, it fed into the communication cycle of the hospital. With the Tufts team, we developed an operational cadence, or what we in the military would call the battle rhythm. This is the cycle of meetings and touch points throughout the organization. The cadence should indicate the frequency, the audience, and the expected inputs and outputs. And as conditions in the crisis change, it should be revisited to ensure that each meeting is relevant. Because I think everyone here can agree, nobody likes a useless meeting, especially in the middle of a crisis. Now, publishing this cadence to all levels in your organization can help deliver some transparency and combat the fear, confusion, and uncertainty that might be felt amongst your staff. Trust is built within your organization if the team understands how information is being processed and decisions are being made. But trust is nothing without our people. And while this could be an entire talk on its own, I'm going to give you 3 people-focused considerations. First is acknowledge. Acknowledge the impact of the crisis on your team. Acknowledge the contributions of all, not just the proverbial front line. Remember, this is a team effort, and sports teams give championship rings to equipment staff, trainers, and others, not just the coaches and the players. Acknowledge the impact to your team's families. They too are making tremendous sacrifice, especially in the medical field. The Tufts Medical Center team made it a point to reach out to the family members of the team, a gesture that was met with great gratitude. And formally recognize loss and sacrifice. This is poignantly evident as we move into the second year of the pandemic, and many amongst us have witnessed or experienced terrible loss. Second, mitigate burnout and complacency. Remember my Iraq story? I was exhausted. And in that immediate incident, I really just had no regard for my own life. But the reality is that my actions and my complacency put my entire platoon and the mission at risk. Complacency is a threat to all leaders. So how do we do this? I offer to you, rest is a weapon. Once it becomes evident that a crisis is going to persist, it is imperative that you implement, encourage, and enforce a rest plan. All hands on deck is just not sustainable. However, in order to do this, it is critical that you, leaders, demonstrate this behavior. You must recognize your own fatigue and you must take time off. Physical and mental pacing is critical to endure. And third, assess your response frequently. Embrace the after-action review process to assess and reflect on what is going well and what could be done differently. This can be an informal discussion or it could be a structured event. And encourage this type of discussion at all levels within your organization. The Tufts Medical Center team did an organization-wide after-action review that examined key events from the first wave of the pandemic. They in turn were able to apply those lessons learned into the second surge. Embracing an open after-action review process allows for unexpected insights and emergent leaders to flourish. Crisis is a test to any leader. It will cost time and resources to invest in processes that outlast personalities, but this investment will pay dividends and prepare your organization for the next major event. You will always be balancing the interests of the public, the patients, the employees, and the enterprise. And while it is impossible to make all of these parties happy, it is possible to build trust and cohesion by focusing on decision-making and people. Leaders, I wish the best to you all, and I truly look forward to the day we can once again gather together, raise a glass, and say, so no kidding, there we were in the COVID-19 pandemic. Thank you for your time today. I'll now turn the floor over to Massachusetts State Representative Liz Miranda. Liz?
Good afternoon. Thank you so much for having me here today with all of you. I'm Rep. Liz Miranda, and I have the honor of representing the 5th Suffolk District here in Boston, in Massachusetts, representing the neighborhoods of Roxbury and Dorchester. A community with abundant talent, great resiliency, and a unique history. I often say that although I've been a legislator now only for 27 months, 2 terms, I've been a Black woman and the daughter of immigrants my entire life. When the COVID-19 pandemic hit our communities of Roxbury and Dorchester, I was not shielded by my role as a legislator. Myself and over 20 members of my family got COVID-19 despite our best efforts to follow social distancing guidelines, wearing our masks, and sanitize. And I also lost my 84-year-old grandmother in 5 days. Our story was not unique. Families in multi-generational households across our district quickly became one of the most impacted communities in the Commonwealth and still remain in that position today. Decades of environmental injustice, over pollution, income inequality, structural racism, lack of affordable and accessible healthy food, and housing segregation were all here before the pandemic and had a devastating impact when COVID-19 hit. My reflection of this pandemic fully realizes the impact and role that pre-existing, systematic, and systemic inequities played in the impact of COVID-19 and what it had on our communities. Although understanding this inequity was not new to me or anyone in my community, the greater public had finally realized and recognized the deep-rooted injustices across systems and sectors in communities of color across the Commonwealth and across this country. Immediately in April of 2020, soon after my grandmother's death, and as I got well, I knew we would have to organize community members in a way that ensured that those most vulnerable to COVID-19 had the information, resources, and community care that they needed to stay safe as the best that they could. We made over 3,000 phone calls to seniors, passed out PPE, multilingual resources were shared, and we delivered hundreds and hundreds of boxes of food. And as a legislator, we filled and filed immediate cash assistance legislation for the lowest income families and the micro and small businesses who are the lifeline in our communities. Despite longstanding efforts, traditional health systems and our social safety net and our emergency preparedness, which we spend lots of money and time on, response were not meeting the needs of communities of color prior to the pandemic. We knew that in a global pandemic, that it would only get worse. But if there were a silver lining and a glimpse of hope that COVID-19 provided, it was that it reimagined and created a renewed awareness, a new self-consciousness, and a greater public recognition of what inequity and injustice really is. We now are in a moment to redefine and reimagine our greatest institutions and systems with an anti-racism and equity lens at the forefront. There was no going back to normal. There is no going back to normal because normal was never good enough. Although this presents as a great opportunity, it is also an incredible responsibility. Building a more just future requires us as the industry leaders to center those most impacted, to lead, to shape, to build the policies, plans, and agendas that will move us all forward. We must evolve to a place where simply inviting those most impacted or most vulnerable to the table is not enough. It's a process of the past. We must shift the burden on us to ensure that we move forward only when the voices of those most impacted have been centered in the decision-making process. We must internalize this notion that lived experience is also credible and very valuable. Conventional wisdom has failed us, even here in Massachusetts, with the best health systems in the world. We were not safe, we were not better off than states with far less resources. And it now highlights for us that the best systems in the world had minimal impact on the outcomes of communities of color. We must say that good is not good enough and not rest on our laurels. Thinking of health systems, we must reimagine what health means in communities like Roxbury and Dorchester. Apply the principles of community organizing work and work harder to understand that we cannot talk about health outcomes without talking about trauma, violence, economic mobility, housing justice, and eminent safety. This work requires us all to be intentional in the ways in which we approach leadership, intentional about elevating those who are living the realities of the most significant challenges we face today. We have rugged individualism embedded across our systems, specifically in health and human services, but that has failed all of us. My community experiences nearly every system from health to the criminal legal system, uniquely, differently, and disproportionately negatively. Building a safer health system requires us all to have frequent individual, organizational, and collective reflection on how inequities came to be and how they are perpetuated. How hierarchies in our system perpetuate poor health outcomes and reverse power imbalances that are inherent in provider-consumer relationships. The most impactful notion that I hope you leave with today is that even well-intentioned allies can unintentionally disempower the very people they are hoping to support. This is true across systems. It's why intentionality in centering those most impacted is critical in our approach forward. And I'll leave you with a quote. When marginalized people gain voice and center their own experiences, things begin changing. And we see this in every grassroots movement. Janet Mock. Thank you very much. Next, I will pass the mic to Josh McDaniels.
Last March 13th in 2020, like most of the rest of the world, we were busy preparing for free agency, preparing for our draft, the NFL draft in April, and getting ready for what was going to be our off-season program in the middle of April, when we got the same call that most people did in the world, that we were going to have some changes. And COVID-19 certainly forced us to adapt and adjust throughout the course of the year. And I'm going to share a little bit about what we did to try to get through our season, stay healthy, be competitive, in a tough and challenging environment. I think the first thing that we did, Bill set a great tone. He was very positive with his leadership initially. When we first heard it, there was a little bit of shock and awe that we weren't going to be able to do our, the normal things that we were able to do on a year-to-year basis. But he had a positive leadership, great attitude. I thought that was a critical ingredient to the overall tone. There was no fear. We kind of embraced what we were going to have to do. And he really did a good job initially when we first communicated that our circumstances had changed. We accepted what was going to happen. He immediately said, this is what, the situation is, and this is what we're going to have to deal with. And so we began by really doing a good job of explaining what our long-term goal was going to be, which was to really stay healthy and safe, and create a safe working environment so that we could continue to do our jobs and ultimately be competitive and make it through the entire season. That was really the goal from the beginning as we began. Once we kind of all understood what the long-term goal was going to be, then we started to develop some short-term goals. And those were really designed for us to be able to work and communicate effectively. We'll get into some of those here shortly. Our COVID committee was developed. We felt like that was important so that we could get voices from each group. Our staff, we had offensive staff members, defensive staff members, our special teams coach, and then we had some players that were part of our COVID committee. And that was really about listening to each other and understanding the challenges we were facing at home, some of the concerns we had about our work environment. I think that was really a good idea right off the bat so that we could kind of gather the collective concern and wisdom of the group and make good decisions as we move forward. Our communication was consistent. We were honest, we were informative, and we made it a point to be that way. Every day we had a staff meeting. We updated the staff on what was happening relative to the restrictions we were under. We had a team meeting every week, and we were able to, really update the team on exactly what was happening. And we created that environment of open, honest communication. Like most people, our workflow changed instantly. And it was important for us to understand that adaptation was going to be a big part of our year. We had no access to our office. We couldn't work through our internal network. We installed our WebEx. That was the way we were communicating. We didn't use Zoom. We used WebEx for all of our virtual work. And we had an entirely virtual off season where we were able to produce videos, put them on the cloud. The players were able to access those, video themselves, send things back to us. So it was the best we could do in a very challenging and different environment and setting. Our video IT and training and medical departments really did an amazing job. Our medical people were on call almost 24 hours a day. The video and IT department, they were early in the morning, late at night, and they were able to facilitate all the equipment that our players and staff needed so that we had a connection, we had processing speed, and we're able to do the things at home that we would normally do in the office. Our work production didn't suffer. We weren't able to be here in the office, but our work production didn't suffer. As I was mentioned, we did everything virtually, but one of the big things we did was we produced voiceovers and we uploaded those to the cloud so our players could access those, whether it was a coaching voiceover or we had apps that we set up for nutrition, strength, and conditioning. And we're able to let the players use those apps to try to stay as close to their normal day-to-day workload and information flow as they possibly could. And we knew it was going to be very important right away to continue some type of team building. Even though we weren't going to be there in person, we were going to try to have the opportunity to continue to build that trust that we knew was going to be really important as we went through the year. And we did that virtually with, Friday afternoon social hours. We did some sharing of family stories and those types of things to continue to build our team. The education piece was obviously very important. None of us knew what we were dealing with initially, but we trusted our doctors, trainers, administrators, our team psychiatrists spoke to us. All those people were involved in educating our team, our staff, and we included the families in that education. They were able to have those productions. We had them at night for the wives so that they were able to kind of catch up on some of the things we were hearing during the course of the day. We developed and communicated our protocols, which we thought was really important to creating a safe environment for us to work in once we got back. We had consistent testing, which was weekly during the off season, daily during the season. We had signage, and as you can see in the picture, hand sanitizer everywhere. We wore tracking devices every time we were in the building. We had mandatory mask wearing. Everyone was socially distanced. We didn't have anybody sitting in the dining hall. We had a note meal app where we were able to order our food. And we arranged different times for locker room use so the players weren't all stacked in there together. And I think it was important. We acknowledged there was going to be some sacrifices we were going to have to make, and that was going to be an important part of what we were doing. As I mentioned multiple times already, our communication was really important. Tracing, testing, transparency. We updated the team on what those things were telling us. If we were tracing and tracking too much together, we made it a point of daily point to make sure we educated the team on the people that were too close together and kind of breaking those barriers so that we could kind of, do the things we needed to do. I think it was important that we created an environment where people felt comfortable sharing and speaking up. We encouraged that. We did that in small groups. We did it in big groups. And I think ultimately we were able to do that and provide our group with an environment that they felt safe to speak up in. We did have some adversity. But we kept our long-term goal in mind. We handled it immediately. We dealt with it directly. We had some positive tests. We did disrupt our workflow a little bit. We didn't make any excuses, but we just had to, we had to do some things in the middle of our season that we wouldn't normally had to have done. We debriefed regularly to ensure we were staying the course in staff meetings, team meetings, the COVID committee, as I mentioned. The medical people gave us great feedback on how we were doing as we were progressing through the year. And I ultimately think that our teamwork has never been more apparent than it was this past season. We needed everybody to do their part so that we could actually get through and accomplish our goal of finishing the season, competing very well throughout the course of the season, and then ultimately being safe and healthy as we did it. I thought we had a positive, thankful environment. Guys were happy to be here. It was important for us to be able to do that, to combat the stress of everything that was happening in our lives. And I thought we kept that vibe very positive throughout the course of the season. We celebrated the small victories with joy, and I rate the word love because that was really the truth. We had a good practice. We were happy about it, and we made it fun to continue to work through the year, even though we couldn't share our work with our families, which for us is something that we look forward to. And ultimately, we reached our long-term goal. We finished safely. We never compromised the most important element, which was the health of our staff and our team and our players. And we were able to try to be competitive and work through the course of the pandemic. So it was a challenging situation like everybody in the world was dealing with. But I think that we all came together. We did our part to try to get through this thing the best way that we could. And we were certainly proud of the effort that everybody put in.
Thanks to all of you. That was terrific. The teamwork, decision matrix, adjusting and adapting, no return to normal. You've given us a lot to think about. I've got a few questions for our panelists, but also invite all of you to send us your questions. Whether the question is for one of the speakers or for all of them, please use the chat feature to direct it to all panelists. And I guess I'd like to start with Sue. I wonder if you could talk a little bit more about the difference between the battle rhythm that you experienced in the Army and at Tufts. Obviously, you created this decision matrix and a plan for crisis, but how do you incorporate what you've seen in this particular crisis, Sue, into the into the plan?
So I think that part of what we were able to apply, and keep in mind my effort, there were several other military fellows that were there with me, and part of what we were able to apply from a military standpoint was things like a battle rhythm or the operational cadence, the critical information requirements, the decision matrix. Those are constant things for us. Anytime we walk into any sort of operation, we can look for those particular documents, whether they look exactly the same, it doesn't matter. That process, when I talk about processes that outlast personalities, that exists no matter what operational, we call it a tactical operations center that I walk into, no matter whether I'm in Afghanistan or we're doing Ebola in Africa, like that similar stuff here. What we were able to apply with the team at Tufts, especially with the emergency management department, was to help facilitate the HICS, the Hospital Incident Command System. And if I got that wrong, I apologize. But they have some of that existing structure in there. This helped filled it out. The challenge, with this pandemic was it impacted everything in the hospital. So creating a process that continued that information flow because there was no current end in sight.
Great, thank you. And Liz, everyone's talking about returning to normal, returning to normalcy, but you're saying there is no return to normal. I wonder if you could talk about, what lessons we've learned during the pandemic and how that can be applied in changing the way people think about some of the issues you addressed with healthcare and housing, emergency preparedness going forward.
We learned really quickly in government 5 quick lessons. One, people speak a lot different languages than English in Massachusetts. We have hundreds of languages, and we were deeply impacted by the need for unemployment and other social safety net programs where we need to be multicultural and multilingual. And that was the first response that I think that we learned early on. Second, that the social determinants of health are incredibly important in addressing how we look at what type of healthcare we're providing to constituents and residents of the Commonwealth. What we found is that we in Massachusetts have 20 majority minority districts, and we have 5 after this last census that have grown predominantly with the Latin base, and therefore we have to reimagine providing help and healthcare to that community because it's largely shifted. For example, communities like Revere, Lynn, Lowell, Lawrence, and Brockton, for example, have seen such demographical shifts that we have to reimagine how we're providing support. Lastly, I'll talk about the economy. 30% of jobs have evaporated. There's no going back. My mom has been a cook in Boston hotels for 40 years. When I got to Wellesley, I was ashamed of talking about that. But now that I'm a state legislator, I often love talking about her membership in the local 26 union. And my mom has been out of work for 16 months. There's an over-dependence, particularly in the gig economy, in the hospitality industry, that just was evaporated. And so therefore, when we're talking about an equitable recovery, what jobs are these citizens going to have? And so I think that part of being in government is understanding that when you're creating policies and procedures, when you're writing legislation, that if you're not taking into consideration the most marginalized and vulnerable people in our Commonwealth, then you're actually never going to get to help saving them. If you create policies that help those that are at the bottom, then we all benefit.
Great, thanks so much. And is Josh here now on the Zoom?
I am.
Terrific. How are you doing?
I'm doing okay. How are you?
Good, thanks. Josh, I'm going to use one of the questions that that one of our audience members sent in. Did during the pandemic, did players live separately from their families? And can you talk a little bit more about the approach the Patriots and the NFL took to rapid testing, contact tracing, and any recommendations for scaling your approach to schools, families, communities?
Yeah. There were definitely times during the course of the year where we were away from our families in hotels. We had a hotel available to us during the course of training camp when we were here all together, and that was really where we were trying to stay away from, just going home every night and possibly bringing it in if we could prevent that. Then we had multiple situations during the course of the season in September and October where we did have a positive test, and then we had a succession of 3 or 4 following the first positive that we had in September. And at that point, anybody that had been in close contact or close proximity to the positive testers, we all ended up in hotels. I myself actually stayed in 2 different hotels during the course of the season at different times. But we knew kind of going into it that training camp was a way for us to start kind of adapting that mentality that we might have to do this a little bit during the course of the season. And we definitely used it. And I think everybody's mentality of keeping the rest of us safe was really important as we navigated the year. You talked about the tracing devices and those types of things. The testing facility was right outside our building the entire year. It's still out there. We're still getting tested. And so during the off season, we had to, even though we weren't allowed here in the building, we were able to come down and test regularly on a weekly basis to make sure that we were all staying kind of, in the range they wanted us to be in and not test positive and then end up, having issues. We tested then. Once we started to actually come back into the building in training camp, we tested daily. And we tested daily from the middle of July until the end of the season. And we didn't really skip any days across it. And I think the biggest thing that I think that we all felt as we were doing that was we were creating a safe environment. The players felt safer that we were testing on a more regular basis than that. And then the tracking devices, and again, I don't know how, I don't know how they could implement those in schools and such. I'm not sure exactly what the cost was to do it, but we all have a tracking device. Mine is right here behind me currently. And anytime, you were in too close of a proximity to somebody, it goes off and gives you a different beep and a color. And then, Coach was really good about sharing that information with us to make sure that we try to avoid any instances where we are too close together for an extended period of time.
Great. There's some questions about leadership, and maybe I could ask Kevin if he's here first off, because you talked about communication, interested in how you connected with other leaders during the pandemic, and what kind of lessons from the other disciplines that our panelists talked about could you bring into Boston Children's?
Sure. The connection with other leaders became probably one of the most important connections for coordination of care in the city of Boston and the Commonwealth of Massachusetts. We utilized a group that we meet quarterly on. It's called the Massachusetts Hospital Association. And in that association are the CEOs, leaders of each of the healthcare entities within Massachusetts. And so taking that as the opportunity, that leadership began meeting on a weekly basis. And having that as an opportunity to meet with state leaders, with leaders within the pandemic response, both locally, regionally, and nationally, was the opportunity that we took to communicate, to plan, and to make decisions upon, and to also coordinate care. And that's one of the key things that I think was very important, in that we took the lessons and the learnings that were occurring in other parts of the country around the world. Italy, for example, New York, for example, and took the issues that they were faced with, the problems that they were faced with, and really understood that part of that was breakdown in communication, the breaks down in communication. And so we were able to really utilize that in terms of our communication structure. Your other question, I think, is also very important in that each hospital has a HIC structure as defined. HIC structures are really great about singular issues. Okay, there's a problem in the IT system. There's a problem in an infection on the floor. But how do you take that structure to deal with a pandemic this large? Was that we need to surround that structure with all parts of the organization in terms of their work, whether it's huddles, whether it's a daily communication at the leadership level, at the CEO, COO level, so that information is not siloed, it is transparent, and it's sent across the organization for planning and the work. And the presentation that you've heard from Susan is really just what we also did at Boston Children's. You'll see across all the hospital organizations and the entities within the Commonwealth in terms of how we created that structure for communication, planning, and execution. The one thing I also add is that in that planning, it was important to do scenario planning, to understand what we were confronted with, what was in front of us, but also to think about what's the 2 or 3 other scenarios that could occur a month from now, 3 months from now, and prepare for that. And so we became more of a preparatory as opposed to a reactionary system. And I thought that was really important for us also.
Great. And a question for Sue. In a chaotic environment, where does hierarchy fit versus a distributed leadership approach, given that we're needing to learn on the fly and must expand and acquire new knowledge that leaders may not have?
Thank you. So I saw that question come through. I was like, oh, it's coming. So I think it's a great question, right? And I think when people think the military, they automatically assume a very strict hierarchy of the way. And there is a hierarchy within the military, without a doubt. But when I come back to those processes that we have built, they are designed to give the leader with the most information on the ground the ability to act, so that they don't have to come back up through the hierarchy to make a decision. So that it's kind of a two-way street. So part of it is at the very highest levels, you have to establish a vision and some guidance and left and right's limits, but then build within those processes of a way in which the leader on the ground at the time the decision needs to be made is empowered to make that decision. And they have to have the trust that they might make the wrong decision, especially in a crisis, as information is constantly changing. They need to know that they are supported and that they will be able to adjust later. That distributed learning and that hierarchy, that distributed leadership only works if the organization has a good way to process information so that a common picture is being shared throughout the organization. Where distributed leadership gets challenged is when people start operating in silos and they only focus on the very small pieces of information that affect them. And they don't ask themselves, and what we always tell our leaders to ask themselves is, now you know, who else needs to know this piece of information? It may just impact what you're doing right now, but that very specific piece of information may help another leader on the ground make those decisions. So that is where distributed leadership is most effective, if you have a common, what we would call a common operating picture, a common information picture. And I think the HICS structure, when put into place, can actually help provide that common operating picture for the hospital. We saw Tufts build that out multiple times to try and create a common idea of, especially when it came to supplies and what we had left over.
Thank you. And here's a question from the UK for Liz. Liz, the questioner says that they have a very different healthcare funding system, and but still saw significantly poorer outcomes in communities of color throughout the pandemic. Reducing inequality seems challenging enough for us. Where do you even start in a multi-payer healthcare system? To which I assume she's referring, or he's referring to, the US multi-payer system.
It's really interesting that you asked that question. Before the pandemic, I had issues that I was working on in terms of legislation here in the Commonwealth: police reform, Black maternal health, immigrant rights. And I got thrusted into this health equity world, not because I had great expertise in terms of healthcare systems, but because I was a community organizer before I ran for office, and I have the most minority district in the entire state. And so I was appointed by Speaker Mariano to the Health Equity Task Force, and then eventually filed 3 pieces of legislation. One was direct cash assistance. We knew that families needed money. We noticed that the federal government, in the transition, did different things, but here in the Commonwealth, we're fully resourced. We're a very resource rich state. And so we wanted to make sure that we tried to figure out what would be the best way to financially support families. Second, there's other pieces of legislation that is to center racial equity and racial justice in all of our policy making. And so we're learning from other states. Connecticut has a really great model that we're trying to replicate here in the Commonwealth, but it's not easy, right? When Kevin talks about meeting with the CEOs of all the doctors, when you have Susan talking about the military approach and then looking at transplanting that in a hospital, and you have Josh talking about the greatest football team on earth and thinking about how you pivot. What we learned about leadership is that we can't make decisions in our separate silos, right? And that was the third and probably the most important decision, is that government needed to lean on our healthcare system. Our healthcare system needed to lean on the grassroots organizations and providers. Folks needed to talk to people in the business community, and we're in this together. And I think we've shown a really good model. I know the governor is probably annoyed as much as I call him and complain, but when we think about vaccine equity, I saw a question about that. Putting a website and a phone number for people to get vaccines doesn't work for all of our communities. We have 351 cities and towns here in the Commonwealth. And we needed to make sure that we had a more diverse, equitable approach to this. So those are 3 quick lessons that I think we learned, and we're pivoting. We're still pivoting. And I think that taking leadership from different sectors is what has provided us great success in Massachusetts, starting sort of at the bottom in terms of vaccine distribution, and now in the top 5.
Great, thanks so much. Let me get one last question in for Josh. And I guess because you're the sports guy, I guess everybody's talking about the pandemic as though it's over and we're taking lessons away, but of course it's not completely over yet. So, I mean, where are we from where you see it? Are we on midfield, the red zone, the 10-yard line? How close are we to the end of this pandemic?
I think it sounds obviously positive in terms of how we're progressing, but I think there's still a lot of work to be done. I think there's still some hurdles to get over. We're in the process of trying to figure out what our off season is going to look like. Obviously, I'm here in person in the building, which is a bonus for all of us from last year. Last year, we weren't able to do that. We were all shut down. So I think we're taking each small victory as it is, and day to day, and trying to make the right decisions that, again, keep everybody safe. I think our long-term goal won't change. We're going to have to do a good job of continuing to not let our guard down, and allow this thing to bother us again this year as best we can. And I think I would imagine that most of the testing and tracing that the NFL and the New England Patriots put in place last season, I would imagine would be replicated again this year. We're already testing. We definitely are wearing the tracers. We're masked and socially distant in the building. So those things are all very much the same. Our hope and prayer is that we're going to have people in the stadium and able to share in the joy of watching our game, and it's one thing we missed last year with our families. We weren't able to share any of that with them. We weren't able to share it with our fans in New England, who are absolutely spectacular. And those were things for our year that kind of made our year long and arduous. But we try to focus on the things that were really important. and stayed to the ball on that and stayed healthy and safe.
Great. Well, that's all the time we have. Thank you to all of you. That was really terrific. I'm going to turn the program back now to Peter and Barbara.
Thank you, Bob, and thank you to the 4 speakers. Just spectacular for all that you managed and the lessons that you've imparted to us. So thank you very much indeed. Barbara.
So our second group of speakers will be sharing their thoughts on how the experiences of the past year could infuse new energy and ideas into our work going forward. But first, we have a short video for you. The Betsy Lehman Center staff spent an afternoon on a sidewalk in Boston asking passersby to share one thing they did differently during the pandemic that they wanted to continue to do going forward. So as you watch the video, I invite you to send a chat to all panelists with the one thing you did during the past year, whether it was personally or professionally, that you'd like to hold on to. And we will share back your responses after the conference.
I took a job and moved here in the middle of the pandemic, and one thing that has been really nice is the way I've been able to, everyone being home has meant that it's been much easier to keep in touch with people. So while it's been a bit difficult to start a new life in Boston the way that I would have planned, being able to keep the connections and I have monthly calls with my best friend from kindergarten. We're now 40, it's been easier to maintain relationships in a way.
You always kind of lose time in the day and you never make that phone call, but now that I'm home a little bit more, I have the time to call and visit.
I'm a lot closer to my husband, even though I thought we were close before, and I sort of adopted being the cocktail maker on Friday and Saturday, and he's our DJ.
You know, the closeness between families during this situation was wonderful.
I've just gotten more consistent with working out, honestly. That's been a big thing. And then connecting with friends as much as I possibly can.
It makes me a lot more appreciative of the times that I can just hang out with friends.
Definitely want to spend a lot more time away from my house, that's for sure. Being outside in public with people.
This year I'm a sophomore and I was on campus last year, so now I'm doing remote. I just recently picked up a job. So yeah, it opened something for me, so I don't mind it.
One thing that I like is telehealth, like having appointments virtually, having them really quick and easy if you don't actually have to go in. Turns out a lot of things you don't need to go in for, and you can just be like, look at this rash, and then in a minute you have your prescription down the street. So I really hope that continues.
So working at home now for a year, full time, has been a big switch. But honestly, I might see myself continuing to do it for a day or two. I live right in this beautiful neighborhood. It's nice to be able to take advantage of it during the week.
We've been going to the trustees of reservations properties around Boston and hiking every weekend.
I've been taking care of my son during this whole pandemic and everything, and it's been hard because I had to do remotely learning with him and I couldn't work. Yeah, despite all the challenges, it kept me positive and it kept me going, and it built me in a way that I couldn't find out, really. I could build this motivation in my system.
I think I consider myself really fortunate right now to be where I am, and I've been taking stock in terms of where I'm going and where I am right now. So I think being able to slow down and just kind of really evaluate where I am with a lot of stuff right now has been really good for me.
Figure out things that they like outside of what you do for a job. I started playing guitar a lot more, which has been good. So
yeah, we're starting a band.
Yeah, we are.
What do you guys play?
Oh, I play the piano.
I play guitar.
I don't play anything.
He plays his vocal. He's the manager. No, he's the manager.
I'm a nurse at Boston Medical Center, and we were going through not only the first wave, but the second wave of COVID. And I think that we spend so much time thinking about the patients that we're caring for that we oftentimes forget how to take care of ourselves in order to continue to do the work that we do. So my focus has been a lot on self-care, and I think that that's absolutely going to continue during this season, the next season, and the next, because it's important for me to be a better coworker, but also a better friend, a better family member, and a better neighbor.
Thank you. Now, we'd like to introduce Martha Bebinger, a healthcare reporter from Boston's NPR news station, WBUR, who will lead the second half of our program, Emerging Stronger. Thank you, Martha.
Thank you so much, Peter, and welcome to our panelists. Nat Kendall-Taylor is the CEO at Frameworks Institute, a MacArthur Genius Grant winner for their use of cognitive and social science research to explore Americans' understanding of complex social issues. Patricia Trbovich is joining us from the University of Toronto. She studies patient safety and quality improvement interventions designed for the healthcare workers who will use them. And Dr. Karthik Sivashanker with Brigham and Women's Hospital, the Institute for Healthcare Improvement, and the American Medical Association will talk about the intersection of equity, quality, and safety in our healthcare systems. Nat, kick us off.
Got it. Just trying to share my screen here. 1 second. Can someone who I can see nod that it's up on the screen? There you go. Great. Thank you very much. Hello, everyone. I hope everyone's doing okay. Hold on. Start my video. There we go. There I am. Hope everyone's doing okay. I've really enjoyed those that last conversation, those last three panelists and the discussion. I'm going to do my best to add my perspective into these ideas in this conversation that's starting. So I'm not anything by background similar to the three people we saw before. I'm certainly not in the NFL. I am by training a psychological anthropologist, and what that means is that I study the way that culture influences how people think, how people use culture to process information and to make meaning of messages. And I have the real opportunity to the honor to lead an organization called the Frameworks Institute, which studies public thinking about complex social and scientific issues. We've done a lot of work on health, and then studies how the way that we communicate, the way that we frame our messages influences those understandings, the way that people think. And so that in altogether is what's called the science of framing. And I'm going to argue here today with you all that framing and the science of framing is absolutely critical to this question of how we emerge from the pandemic. And so before I get any further, I want to establish a common definition of what framing is. It's one of these terms, one of these words that has become so ubiquitously used that I fear it has lost any and all meaning it ever once had. So a common definition of framing, when we talk about framing, at least for the next 7.5 minutes, what we mean here is the choices that we make in how we present information. Those can be really small, seemingly innocuous decisions. The pronouns that we use, do we talk about us and them, they, those, or do we talk about we? Sometimes the really obvious things, the values that we endorse and choose to advocate for why our issue and addressing it matters so much. So framing is about how all of those choices, both big and small, influence how people think, how they feel, and what they are or not willing to do as a result of hearing our communications. And before I get into kind of my pandemic relevant points, I want to take a step back and just give you an example of framing that I think is relevant to the healthcare field and the healthcare sector. So as an organization, we have done a lot of work over the years on early childhood development, trying to communicate and frame these issues in a way that advances public support for the kinds of policies that support children and families and healthy development. And an issue that we and our partners have struggled with pretty mightily is the issue of child mental health, convincing Americans that young children can have mental health and getting them to be supportive of a set of evidence-based policies that would do a better job of supporting mental health in this country. So we're going to get a little geeky on some data for a second here, but I'll walk you through all of it. So what you see on the screen now is an experiment that we ran about 3 or 4 years ago, in which we tried to see if framing the issue of child mental health, presenting information in different ways about child mental health, could influence people's support for evidence-based policies. And so what you see along the horizontal axis of the screen are the 2 different ways that we chose to frame this issue. So it's an online experiment. It's conducted with about 6,000 different people. And the way that it works is person one logs on, they get randomly assigned to read about a child mental health program. And the frame, in this case, we'll say collective progress and prosperity, is the first sentence, is the first line of what they read. And it goes something like, we need to do a better job of addressing child mental health because, and we wouldn't say it in such a cliched way, children are our future, they're stable mental health, their positive development is key to our ability to move forward and be successful as a country. Person number two logs on, they get randomly assigned to the other frame. They read the same 80 words about the program, except that first sentence, the frame, is different. Instead of collective progress and prosperity, it's about vulnerability. And it would go something like, we need to do a better job in this country of addressing child mental health because children are our most vulnerable citizens, right? They deserve our empathy and our compassion, and we must do better by them. And then there's a third group that gets no message. They're the control group, and they all answer a set of questions that are designed to measure how supportive they are of this set of policies. So what you're going to see on the next click here are what I personally think are two absolutely gorgeous green bars are going to appear on the screen. And what those bars are going to show you is the extent to which hearing those different frames, those different ways of positioning the issue, affect people's support for policy. So you'd see two bars and you notice two things. First of all, that collective progress prosperity value is increasing to a statistically significant degree how supportive people are of those policies. That's the good news. We celebrate when we get those findings. But you probably also noticed the second thing, that value of vulnerability is having the opposite effect. It is depressing, it is decreasing people's support for those policies. And the really interesting thing is that in a subsequent analysis where we looked at all the field's communications for a 3-year period, the value of vulnerability was used in over 93% of those communications. So in essence, what the field had been doing, and this happens in a lot of fields, is inadvertently choosing and landing and using a frame that was not only wasting their communications resources, but using them in a way that directly disadvantaged their goals in terms of policy and change. And so I've come to talk about framing using this metaphor of a key. And I think this is really powerful in the current context, that framing has the ability to, the choices that we make and how we present information, to open space for people to think about issues, to see issues in new ways, to have new conversations, to consider and support new solutions. But it also, as we just saw in the vulnerability example, can do the opposite, right? It can close down conversation, it can lead people to reject messages, and it can lead them to turn away from solutions. And so I think framing has always mattered, but I think it matters a whole lot right now. And I've got 3 examples that I'm going to put on the screen that I've been collecting over the last year plus that really show the powerful effect that framing has. And so they go from kind of most obvious to most nuanced. The first one, the initial framing of COVID as being the Chinese virus. There's a lot of research being done and the effects currently being felt of the way that that frame created a palpable fear of other and invoked a strong sense of racism that attached obviously to Asian Americans, but also interestingly to other groups of people. Slightly more nuanced, all of the framing around vulnerability with good intention, however, having a negative framing effect in othering those groups that we are labeling vulnerable and increasing perceptions of stigma of those groups and of stigma felt by members of those groups. And then finally, and I think maybe most provocatively, this discussion about healthcare heroes and the way in which focusing on individual members of the healthcare community and rather than systems powerfully individualizes our perception of responsibility and obscures the social determinants that Representative Miranda talked about in the previous conversation. And so we are, without a doubt, in a period of social upheaval and cultural flux where our fundamental understandings of how the world works that we kind of normally take for granted are being brought up and drawn into focus as we negotiate and contest them. And I think and feel very strongly that framing and how we position our messages is going to be absolutely key in where those issues come down when the dust settles as we emerge from the pandemic. And with that, I will thank all of you and I will hand over to Patricia Trbovich, who's going to speak with you next.
So hello, everyone. In preparing for this presentation, I was really excited. After waiting 5 months to get my hair done, I finally got an appointment. And then I didn't. Things were supposed to reopen and then they didn't. And that's just the uncertain world that we're currently in. And although this is obviously a mundane example, and I certainly do not want to trivialize the more consequential and even catastrophic impact that the pandemic has had on so many people. In fact, I want to do the opposite. If ever there was a time where we needed to underscore the human and human factors, it's now. In a world where we've normalized burnout, inequality, exhaustion, where we continue to confront chronic uncertainty, we need to really think about how can we better position people for success. I lead a team called Human Era. It's a deliberate play on words with human error. And the reason for that is that we're trying to move beyond the current tendency in healthcare, which is often to view humans as the source of problems and blame them for the errors that they make. And instead, usher into a new era of healthcare, where we encourage people to come forward with the errors that they make so that we can learn from them and in turn build better and safer systems. So my area of research is human factors. And human factors is essentially all about how to position people for success. So what I'd like to do today is highlight 4 principles that I've extracted from my team's research on applying human factors in healthcare that have profoundly changed not only the way I think about how we position clinicians for success, but how we position people more generally for success. So principle number 1, know your context. Are you in a context of low uncertainty or high uncertainty? Or as Robin Hogarth would state, are you in a kind or wicked environment? Our kind environments are our low uncertainty context, wherein the next steps and goals are known. The patterns are clear and they often repeat themselves. When you do something, the feedback is immediate and accurate. And so work next year will look like work last year. Wicked environments are our high uncertainty context, wherein information is hidden, meaning that the next goals are not known, the next steps are not known. Here, the rules are changing. You're getting an influx of data, and it might be changing without prior notice. When you do something, the feedback is delayed and sometimes inaccurate, and work next year will not look like work last year. Or as we've all been living through in the pandemic, work tomorrow will not look like work yesterday. So the point I really want to drive home here is how you position people for success under low uncertainty is going to be completely different than how you position them for success under high uncertainty. Under low uncertainty, we know what the evidence best practice is, but this is just half the battle, especially when you're dealing with human beings, because the next thing we have to figure out is how do we ensure that they follow that best practice? So as human factors researchers, when we're trying to come up with interventions under low uncertainty, we're trying to decrease discretionary behavior. We're trying to figure out how can we standardize a process such that everyone is doing it in the same way, that we're all rowing to the same beat. And in essence, what we're trying to do is remove the decision-making as much as we can from the action. So examples of interventions that work well here are things like checklists, or better yet, automating a task, or the holy grail is creating a forcing function where you simply make it impossible to do the wrong action. Now, if we contrast that to our high uncertainty environments, again, this is where we don't have access to the evidence best practice. We don't know what the solution is. So the best we can hope for is that we come up with a strategy that's going to help people improvise, adapt, and overcome that uncertainty. So as human factors designers, when we're designing interventions under high uncertainty, we're focused on increasing discretionary behavior. So whereas under low uncertainty, we're really trying to remove the decision-making as much as possible, it's the complete opposite under high uncertainty. Under high uncertainty, we rely on the human. It's hard to imagine a more important skill that one would need under high uncertainty than critical decision-making. So here, we're really focused on interventions that are focused on adaptation. And I would argue that in healthcare, we tend to overvalue standardization and undervalue adaptation. To be clear, both are needed, but knowing when each is required is key. So principle number 1, know your context. Principle number 2, recognize the drift. What makes healthcare particularly risky business is Not only do you have to have the skills to work well under low and under high uncertainty, but more importantly, you also need to have the skills to recognize the drift. Low versus high uncertainty is not dichotomous. It's not dichotomous, it's on a continuum. And our research shows that low performing teams fail to recognize the drift. When low performing teams drift into higher levels of uncertainty, communication tends to dry up. High performing teams, on the other hand, when they drift into higher levels of uncertainty, they communicate, they voice that uncertainty and their thought process. We'll hear things like, I don't know what's going on, but I'm going to try X, Y, Z. So the point here is that when you're trying to manage that drift, you want less certainty, more inquiry. In healthcare, we tend to overvalue certainty and undervalue inquiry. So if you want to position people for success, recognize the drift. Principle number 3, know how to define success. Under low uncertainty, the safety 1 definition of success, which is to define safety as the absence of error, works well. Because again, here's where we know what the evidence best practice is. So not only is it an aspirational goal, but it's our obligation to remove error when we know how to do so. But if we take that definition of success and extrapolate it to our high levels of uncertainty, we are no longer positioning people for success. Because again, here, we don't know what the evidence best practice is. So the safety 2 definition works better, which is to define safety not as the absence of something, but by the presence of something. And that something is resilience. People's ability to bounce back, absorb disturbance without breaking down, without catastrophic failure. Under low uncertainty, we're really focused on the outcome, 0 error. Under high uncertainty, we should be focused on the processes. In healthcare, we tend to overvalue outcomes and undervalue the processes that got us to those outcomes in the first place. So if you want to position people for success, know how to define success. And finally, principle number 4, know your people and know how to unite them. Just like we have low and high levels of situation uncertainty, we have different comfort levels. Your risk-averse people are going to be comfortable under low uncertainty. Your risk-tolerant people are going to thrive under high uncertainty. And you, as the organization leader, you need to go back to principle number 1 and know your concept, know your context, and be transparent about that context. If you've come up with a policy and you're not too sure about it, you're over here. You're not sure if you're going to need to change that policy tomorrow. Let your risk-averse people know that. Let them know that you know that that makes them feel uncomfortable, that you recognize that they would much prefer that you would implement a policy and guarantee that it will not change tomorrow, and that you will ensure that everyone complies to it. But you can't, because that's not the context that you're currently in. Just being transparent with them about that will show that they're being heard and will show some compassion. Likewise, when you do come up with a policy for which you do have evidence best, so it is an evidence best practice, so now you're under low uncertainty and you want to ensure that people comply with it. If your risk tolerant people fail to comply to that policy, you want to resist the urge to chastise them for having failed to comply to the policy. Because after all, to err is human. And so instead, what we want to focus on is what have we learned from this and how can we move forward together on a common front? In healthcare, we tend to overvalue being right and undervalue getting it right. So if you want to position your people for success, know your people and know how to unite them. And how you're going to unite them is by being clear on what you value. So to summarize, if you want to position people for success, know your context and value adaptation over standardization. Recognize the drift and value inquiry over certainty. Know how to define success and value the processes that got you to your outcomes, not just your outcomes. Know your people and how to unite them and value getting it right over being right. Thank you very much. I really appreciate this opportunity, and it's my pleasure to now hand things over to Karthik.
Thank you so much. So I'm Karthik Sivashanker. I'm Medical Director for Quality, Safety, and Equity at Brigham Women's Hospital, and also Vice President for Equitable Health Systems and Innovation at the AMA. And I'm actually going to go off script for a moment, just listening to all the great speakers and the themes. I want to build a bit on Nat's emphasis on framing to basically zoom out a bit and reflect a bit more on root causes for some of these conversations, because that's what my work has really been about. It's about quality, safety, and equity, and how do we operationalize equity in healthcare And as you know, quality and safety is about getting to root causes. So let's talk about that for a moment. And it really begins by thinking about the broader ecosystem that we're operating within. And the health ecosystem specifically is grounded in the same hyper-racialized, quasi-capitalistic, and increasingly global financial system. And all of that can be traced back to our original sin and economic enterprise of slavery. And so why am I talking about slavery? Well, it's been our most horrific and enduring innovation in the way it was carefully designed, adopted, diffused, normalized, legitimized over time in healthcare and beyond. And it was uniquely operationalized in the US by justifying its existence through these quasi-scientific and medical theories. And those deeply entrenched myths and stereotypes have persisted to the present day, implicitly reinforcing a system of wealth and social inequality, essentially designed to benefit a few over many, and driving a wedge between people of color, poor white folks, and other historically oppressed groups. And this entire industry, including in healthcare, has grown out of and around slavery. And rather than correcting historical injustices, we've seen that innovation in US healthcare has oftentimes compounded the problem. It's reinforced it, it's amplified existing inequities, or led to unintended consequences for historically oppressed populations. And a classic example would be, this is a classic one, is Marion Sims, the father of modern gynecology, who invented the vaginal speculum, very painful testing that he did on enslaved women, and an example of literally using the womb of Black women as an engine of capitalistic innovation. So if anything I'm saying is sounding shocking, none of it really should be. If you think about our history as a country, the last 400 plus years, only a small portion of that history, about 14, 15%, has been in a time that's not slavery or segregation. And in this modern era, we have the war on drugs and mass incarceration and felony disenfranchisement and all the other things that we see. And so when we think about COVID-19 as a catalyst for some of these conversations, and our ability to anticipate the differential impacts of COVID-19, none of that should have been surprising either, given our history. So to me, COVID-19 is a stark reminder of the peril of doing the work that we're doing when we disconnect our work from core principles of morality and equity and justice. And my worry is that what I'm seeing is that there's still innovation happening in this disconnected way that is broadly continuing this legacy of exploitation of natural resources and people, oftentimes focused on profit and oftentimes benefiting only a few. And any social justice efforts that we try to lead are forced to operate within or contend with that system, this hyper-racialized, quasi-capitalistic system, and inevitably has to overcome the question that'll come of what's the return on an investment? What's the ROI, usually by leaders in power? So if we're going to address these problems in healthcare and beyond, we have to start asking some fundamental questions and really start to re-examine our assumptions and start to dismantle some of these structures, including some of the current financial structures and motives that incentivize us to take care of the folks who already have as opposed to the folks who do not have. And so some of those questions might be, who is benefiting and who is not? Who's designing and who's being left out? Are historically marginalized groups being recognized, elevated, and centered? Have we thought about unintended consequences for historically marginalized groups? How will we measure that impact? And will our efforts lead to equitable reallocation of wealth and power and resources? That's what we're really talking when we talk about equity. So how has organized medicine responded? Because we've known for decades now, through hundreds and hundreds of reports, that we are providing dangerous and potentially fatal undertreatment of Black, Brown, and other populations. It's usually expressed in healthcare as passive academic descriptions or gestures or sentiments or expressions of concern, euphemisms, mild expressions or indirect expressions, rationalization by good intentions, he or she didn't mean it that way, or delaying tactics or half measures, usually framed in a colorblind way, oftentimes through the lens of bias. And all the while acknowledging, yeah, we're still not doing a great job of serving our Black and other historically oppressed groups, and they're not receiving the same level of high quality care as our white patients in American hospitals and clinics. So that really brings us to the present, which is Well, let's actually go back to that for a moment. How else have we tried to respond? What we usually see systems do is, for example, after this conversation, folks might be thinking, well, we need to do more around equity. Well, we'll usually hire 1 or 2 people of color. We'll under-resource them. We'll tell them to solve the problems of racism and discrimination in this country, problems that they didn't create nor benefit from. And then we're surprised when it doesn't work. And that's how we've been doing it. So the future really is that we are embracing equity as a core mission, as a core value of the work, and that we're folding it into our quality work, our cost control work, our operational work. And this is about my work now, which is really, and really a lot of other folks' work, is how do we embed equity and quality and safety? Why does that make sense? And the takeaway here is there is no such thing as high quality and equitable care, and yet we consistently deliver highly inequitable care in this country. And so we're not delivering high quality care if it's only to a small proportion of the population. And quality is actually built into the definition, or equity is built into the definition of quality. It's part of the IOM definition. It's just been one of the forgotten dimensions. So what I'm interested in, and other folks in this work are interested in, is getting to those root causes and getting to impact. So how do we advance equitable, high quality care? How do we embed equity in access and coordination of care? How do we elevate awareness and understanding of structural racism plus, meaning leading with racism, but never to the exclusion of other isms? How do we embed equity in our health system accountability, tracking, monitoring, reporting, in our quality dashboards and our performance metrics? How do we develop the next generation of physicians who are not just quality and safety leaders, but who understand that equity is a fundamental component of that? And then how do we work across sectors to advance this work? So I'm going to pause there. I didn't actually get into the main body of what I was going to discuss, but hopefully we'll have some time in the Q&A. I just felt like it would be helpful to take that step back and to provide that broader frame for us to think about. Thank you.
Terrific, Karthik. Thank you. Thank you to the other panelists and to everything that we've heard so far. So much to dig into. Many of you are already posting your questions in the chat window, which is perfect. We'll get to those in just a minute. Karthik, I want to follow up with you right away, though, to ask how we start to dismantle these hyper-racialized systems that you were describing. If you ask the question, who's benefiting and who's not, can you give us an example of how you start to untangle the years of disparity embedded in that question?
Oh gosh, there's so many examples. It's hard to. It would be easier to name an example. All right, let me try my best. Let's start with like telehealth, for example. Well-intentioned. We need telehealth right now with COVID-19. Obviously, there's a lot of opportunities and possibilities with telehealth, but there's a lot of risks as well. So I see patients up in Lynn, Massachusetts, and most of my patients are poor, and very few of them have broadband internet or smartphones, and I have to see them usually via phone call. Thankfully, right now, we're reimbursing at the same rate for telephone visits and video visits, but some systems are already starting to incentivize their providers to do video visits instead of telephone visits because they're anticipating a change in that reimbursement structure. And what would happen then? Well, all those patients who don't have access to video visits will be left out. And that's just one of thousands of examples. The other way to put it is anytime we design anything, it's the folks that have the resources who are more likely to take advantage, and the folks that don't are less likely because they're in survival mode. They don't have the time to get onto the patient portal or to interact with that navigator. So we have to design with some intentionality for those groups. And by designing at the margin, we will make care better for everyone. Meaning if we have a system that's so reliable and resilient that it works for our most historically oppressed groups, it'll absolutely work for everybody else even better.
Thank you. Nat, I want to bring your framing perspective to the issue of masks. And my question is, we expect to keep wearing masks for quite some time, certainly within healthcare systems, and yet we still see people who are very resistant. What does your framing tell us about how to help people understand the collective prosperity that masks might yield?
I thought you were going to ask me about how framing can maybe help with structural racism, which is also a exceedingly difficult question. But
hey, if you want to start there, do it.
No. But one where I think a lot of the way that Karthik spoke about it is kind of doing all the right things. So maybe I'll start there and I'll go to masks. I think so. We have some research going on right now that's started in June, and has been kind of looking at how cultural shifts have or have not been happening. And one thing that we're seeing pretty powerfully is that there's a lot more talk about systemic racism or structural racism, but very little evidence yet that people's actual thinking behind that language has shifted. So you'll have people acknowledging structural racism when it comes to policing or justice, but then when you ask them to talk about examples thereof, you get individual examples of basically rotten apples kind of thinking, like a bad cop here, a crooked judge there. So I think what needs to happen on that front is there needs to be a lot more explanation about how systems are set up intentionally and historically to disproportionately influence certain groups of people. And I think that is explanation that needs to be done very carefully and put on repeat. I mean, we need to be continually building that into the way that we talk about how systems work and affect individuals. And that it's not going to be a one sentence slew of magic words that's going to suddenly, create aha moments where people understand everything about structural racism. I mean, I think on masks, I think the unfortunate thing is the way that something that really isn't in any other country a culture war issue got made into one, and that once something is kind of firmly in that lane and vein of being a culture war issue, it's exceedingly difficult to kind of frame it in more positive and effective ways. As soon as something kind of tips off our polarization radar, it's really hard to get people back from that kind of motivated reasoning way of thinking towards a pragmatic and pragmatic one. I mean, I think the emphasis around common benefits and collective good would have been my recommendation, which is largely what's been happening. And I think that the problem is it's just been grounded in a discourse around identity and ideology that makes it exceedingly difficult to kind of claw it back and reframe it.
Thank you. Patricia, how do we apply the human factors research to the idea of dismantling racism within healthcare?
Yeah, that's a really interesting. I think that there are so many different layers to that, but I think first of all, it goes back to really valuing our people. And I would say, like, of all the principles that I talked about, the last one about really knowing our people and finding ways of uniting them. And I think one of the things that the pandemic has really shown us is that although sometimes it can be tempting to really be trying to focus on what's good for me individually, what we really have to come to is really understand what's good for us more as a society. And, I know some people feel that we're incapable of that because people are just selfish, but maybe I'm too Pollyanna, but I really believe that we can, and that's really, it's very basic, but the first thing that we really need to do is be more open and accepting of people and not expect, that we are going to be the same, and value those differences.
Tricia, I'm going to stay with you for just a minute on the question of adaptation. It seemed to me from the outside that it was valued a lot during the pandemic. There were endless discussions about how to use proning, for example. So when you talk about the drift, where are we in that drift now? Are we starting to standardize within the COVID response, or do you feel like we still need to be in the adaptation inquiry focus?
I think it depends on the time and the topic, and I think that's the whole point, is that you're not going to always be in one end or always in the other. I think we see it all the time. The restaurants are opening. I can go to the bar. No, I can't. And we saw it too at the beginning, like with wearing masks. A lot of people, there was a lot of uncertainty around, is this something that we really need to do? And now I think for the most part, it's something that has been more standardized and people realize that we need to do that. But I think that what's key is to not get so fixated on being in standardization or an adaptation, but to really appreciate the fact that what makes this so risky and risky business is that you're constantly going to have to navigate from one end to the other.
Right. Karthik, this is a question from Betsy Lowe, and she asks, when thinking about inequities in framing, how do we encourage patients and families to speak up? I don't know what your experience in Lynn there is, but she's suggesting that we need more feedback, more flexibility to meet the needs of those people we serve. How do you see that?
Yeah, I think this is really getting to the approach that we've designed and implemented at Brigham and Women's Hospital that we're now recentering at the AMA as a national approach, which is how do we embed equity into all of our quality and safety processes, and specifically with safety into our safety event reporting, into our patient complaints. And we can do that in various ways with our reporting solutions, embedding the questions into our reporting solutions, into our trackers. And so it becomes a standardized way of identifying inequities when patients or providers are reporting inequities, and that automatically flag an additional equity review that we can then apply our high reliability approaches to. So one of the things, hopefully I'm answering the question, one of the things we saw with COVID-19 was in real time, we were getting reports from employees, from staff, from patients about inequities, and we could then respond very quickly to those in a standardized way with a focus on redesigning policies and practices and systems, because that's what's perpetuating these inequities. It's not usually individual bad actors that's a part of it, but it's really built into our structure. So hopefully I answered the question.
Betsy, you'll let us know if you want more, okay? Thank you. Nat, there's a question for you about whether we are too embarrassed to admit that we're maybe involved in these negative concepts such as racism, and should we reframe to somehow think about progress in the conversation as a society? I don't know if I got that, Zaf, but is there too much, are we too maybe embedded in blame and maybe too much on that vulnerability part of the scale that you showed us earlier?
Yeah, I mean, I think there's like at least 2, maybe 3 questions in Zaf's comment there. I'm gonna use speaker prerogative to choose the one that I think I'm most able to answer. Hopefully that's okay. I think there's something in that question, or there's a question in that comment that's really about kind of framing as kind of problems and around disparities versus framing around future and aspiration. And there's been a lot of work in my field, especially over the last 3 to 5 years that's looked at that. And I think it's really interesting as applied to issues of structural racism. And the overwhelming and grossly simplified finding of that work is that messages will not be effective if they only focus on the problem, and if they describe disparities and get stuck in obstacles. They also won't be effective if they get all kind of woo-woo, hopey, changey future and don't acknowledge the problem. And that social scientists have found a really powerful combination kind of in between those ends of the continuum, where you need to acknowledge and cue the urgency of a deep problem like structural racism, but pair that with an equally robust sense of kind of a solutions, vision, future, aspiration. And when you're able to create messages that do both that urgency and supply that sense of efficacy, you bring people in, but you give them a place to go, rather than bringing them in and getting them stuck in actually inadvertently reinforcing a lot of our stereotypes and stigmas. So this has been work that's been done around structural racism. It's also been work, interestingly, that's been done around gender. Some interesting studies that show that messages that focus on obstacles and challenges that women face actually reinforce gender stereotypes, rather than focusing on kind of where we want to go and an aspirational vision for a future that we want to see. So kind of moving from obstacle and challenges framing to what one of my colleagues calls power framing is a really interesting shift in how we're constructing mobilizing messages. I don't know if I answered Zaf's question at all, but I wanted to say that.
Zaf will tell us. Yeah. Patricia, that strikes me as that that's kind of talking about a similar paradigm to what you're describing with certainty and uncertainty. You know, trying to move towards a healthcare system where equity is at the focus. Do we know right now how to define that? Do you think? Do we know what success would look like in your emphasis on measuring success?
Well, I think one thing's for sure is that we really need to change where we put our emphasis, even in terms of our research. I don't think that there's enough research that is looking into some of the socio-determinants of health and their impact on healthcare or socioeconomic factors as well. And I think this also factors into when we're analyzing our data, or even in terms of our own approaches. I know in human factors and quality improvement science, for example, we often pride ourselves on doing these rapid cycles of learning and improvement. But with rapid cycles, you're often only looking at a smaller sample size. And so it's important that we start to think about this more and think about what are we leaving out in terms of our learning, and are we incorporating the right populations in what then ends up being our interventions that we come up with.
Right. Unfortunately, I think we're going to have to wrap it there and move on to our final speaker. But I thank you so much to all of the panelists. If you have a minute to take a look at the chat and respond to some of the things that you see there, I know some of you are doing that already. Fascinating questions. We're going to hear now from Don Berwick, Dr. Don Berwick, President Emeritus of the Institute for Healthcare Improvement and a global leader in systems that improve quality for patients and everyone involved in healthcare. So thank you, Don. So glad that you're here.
I'm glad to be here, Martha. Thank you.
I bet you have some initial thoughts on that conversation you were just hearing. Can I just get your reaction to what we're discussing so far?
Yeah, well, I am having major reactions. One is you shouldn't switch the camera to me, but go back to those amazing panelists. They have so much to say. Look, I was the chair of the National Academy of Medicine subcommittee, the IOM subcommittee that wrote those 6 aims for improvement that Karthik talked about. Safety was listed first, then effectiveness, patient-centeredness, timeliness, efficiency, and equity. I think we erred in putting equity last. I think one of the takeaway lessons from the COVID era, amazing eloquence that you just heard from Karthik, we are really finally, hopefully, coming to a reckoning with how horrific the heritage of inequity in this country is. And so one takeaway I have is let's take everything we know about systems improvement, and we know a ton, and apply it there with as much diligence as we're asking for the other dimensions of quality. That may not be what you're asking me for, Martha, but it's time to get on this and as far as we can put this behind us by looking it in the face and dealing with it.
You know, early in this conversation, we heard from Representative Liz Miranda about all of the social determinants of the health that were contributing to the inequities we saw inside the hospitals. And I know that's something the Brigham has tried to address. Karthik alluded to just a few minutes ago. What is the role for hospitals, Don, in dealing with the safety and quality issues that start well before a patient walks into the front door?
Big and different from what hospitals are thinking about now. That's what I've come to believe. I don't have the burden or luxury of running a hospital, so it's easy to be glib. But I take my lessons from Sir Michael Marmot, whose book, The Health Gap, I've been talking about ever since I read it. It was written in 2015. Marmot talks about social determinants. He has 5 of them in his book. He analyzes the literature about childhood experience, education systems, workplaces, elder care, and community infrastructures. Those are, quickly put, the 5 categories he discusses. But then he adds a 6th one, and that is fairness. He means equity. He means solidarity. He means a sense that we're all in this together. And he calls that the cause of the causes. And the more I've looked at this and really been forced to confront it by the modern sensibilities, I've come to believe that until we feel together and unified, we can't work on the other dimensions. Now, if we do that, we're all part of the problem. We have to join it. And in hospitals, the American healthcare system, with 18% of the gross domestic product, it doesn't have the right to be a bystander to the social determinants that are causing people to come into those hospitals. That means a change in business models. It means a change in financing. It means a change in political energies. But I've stopped feeling embarrassed at all about calling on the hospital community to become part of the solution to the problems that we're talking about when we say social determinants. They'll say, some of them, we're too busy, or we have so much to handle, or we're not getting paid for it. And I say, figure it out. I don't see a bystander possibility here.
Well, you and I have talked before about some pretty unique collaboration that happened during the pandemic. Is that the path forward when you're looking at, let's just start with the social determinants. What would that look like?
Again, I fear I'm being glib, and I don't mean to be, and we all have to think hard about this and get to better answers than I'm going to give you to that question. But the pandemic taught us that we're in this together. When someone wears a mask, whether someone wears a mask crossing my path, affects me deeply, and vice versa. We can't deal with the medical consequences of COVID without teamwork, immense teamwork. We have to reach into communities and help people become comfortable with vaccines. We have to help people who are distressed by job loss. We have to come up with infrastructures that support people who are really at great disadvantage because of the COVID pandemic. It's all of us together. And I think you asked me, in preparation for this interview about kind of the lessons, and the one that keeps coming back to me is that it's a lesson about solidarity, about oneness, which is not a very American term. We experience solidarity in Normandy beaches, maybe, or in real security threats. We're experiencing a bit in the pandemic, but we haven't used it in addressing the causes of illness. So it's a lesson I'd like us to read out of this, that we've got to work together differently. In pandemics and 21st century threats, regional responses are really crucial. And so beginning to think outside the walls of organizations and realize that regional assets need to be organized to bring to bear on public health issues and the kind of trauma we're experiencing in population, that's a lesson. And that's the kind of solidarity I'm talking about.
So what would help us continue that solidarity? Are there new institutions that need to form? Are there payment changes that we need to see? Are there more cross-affiliation licensing agreements? Talk us through that a little bit.
That's not a bad start to the list. I really believe financing changes are needed. They may not be, they're neither necessary nor sufficient, perhaps, but they sure would help. One of the people chatted in, Dan Hyman, I think, asked about global budgets or global or health single payer universal health coverage. We would think differently if we had national health insurance in this country. We would simply think differently about how we're all in it together. Someone's gain becomes someone's loss is my loss too in that circumstance, not when we're so fragmented. So maybe we're not going to get there politically, but that would help. Leadership matters. They say the currency of leadership is attention. And just like in the world of safety, one of the big struggles we've had is to tell boards of trustees and executive suites that if you're not talking about patient safety, every meeting, every agenda, it's not going to happen. It's got to, the currency of leadership is attention. I think the same applies to this sense of responsibility for the social determinants and ways to become engaged. I think we probably need new structures. We don't have strong coordinative structures for regional responses. Two examples that leap to mind. One is the opioid pandemic. I mean, it really is a problem. I mean, tens of thousands of people dying. We haven't come together as a community and say, all right, let's stop this one. We don't appear to have the structural support to do that. Another is housing. We're one of the few wealthy nations that really tolerate homelessness and hunger, and we don't have the structures. When I was on the Biden-Sanders Unity Task Force that made recommendations to then candidate Biden, one of them is, I think this is in the Oval Office. We have to have a presidential level leadership for bringing everyone together around the concerns about equity. And I think we may be starting to see that, but that structure is going to be needed.
So on timing, what is the inflection point? What's the pivot point where we say, okay, we know what we need to do. Now the change happens. Are we there now?
No, I fear that, I think you and I, again, in preparation, I had this idea of the difference between a slow emergency and a fast emergency. Yes, with COVID, we're going to beat COVID. I mean, everybody's mobilized now. We have a government that's got a brain and really kind of working hard at it. We have very superb scientific infrastructures, at least within this nation, if not around the world. COVID will be behind us. We'll say, been there, done that, it's over. That's not going to happen with the slower suffering of inequity and racism and its heritage, as Karthik was talking about, nor will it happen with other problems that are very serious. Climate change keeps me up at night. And how can we mobilize this kind of energy for collaborative work at the level of problems that are not quite so headline grabbing every day? And I don't know the answer. I hope COVID's a turning point in that sensibility. And I think if, again, I'll turn to the government, if President Biden is able to help us see the larger picture of what it's like to be a country where compassion and cooperation are at the top of the list, how much better off we all will be. I'll try to make it Nat's framing. Think of a world in which we actually help each other and how good that would be. And I think that's got to apply to the issue of racism, and maybe it's a way to think. Inflection point, I don't know. I sure hope so.
I want to stay on this point about urgency and the value of the intensity during the pandemic to produce a lot of rapid change and a lot of collaboration. Can you have those same results if you don't have the urgency? And if you can build in, Don, I'm also like, how do you deal with burnout amidst all of that?
Yeah. Okay. So there's 2 points there.
Yeah.
We need to be able to establish a sense of urgency about problems that we've lived with for a long time. And I don't know now, the street camera that films the murder of George Floyd helps. There's a kind of transparency around that tragedy, that awful murder, that does kind of create an opportunity to say, wait 1 minute, what's going on here? So yes, I think our new media and our new ability to watch and communicate with others could help create a sense of urgency. Burnout, yeah, it's an interesting issue. Right now in the pandemic, since we never built the infrastructures for psychological support to the healthcare workforce, instead, as Nat said, we frame them as heroes. They get tired and worn out. And one of the really nice things going on now is I think there are organizations all over the American medical scene that are saying, wait a minute, if we don't attend to the psychological needs and stresses that these very, very good-hearted workforce, including the people that serve food and drive the vans in hospitals, we really can't have a compassionate, successful healthcare system. So that's turning around. But now, what about burnout for the more chronic problems, like ending racism or stopping climate change? I have a different view of that. I think the workforce wants to do that. I actually think one of the problems that actually colleagues have called moral injury is we disconnect workforce from things they really care about. And I'm pretty romantic about it. I think if we invited the American healthcare workforce become not just party to, but leaders in solving problems of the magnitude of racism, I think people will step up enough. A lot of people will step up. And my guess is it may have the opposite effect from burnout. It may be finally I get to add meaning to my life. So call me naive, but I think there's a possibility there. I've seen it in safety. When you drill through the board of trustees or the C-suite in a hospital and finally get focused on safety, man, oh man, people will get engaged at levels that they've always wanted to be, but now you've given them a chance to do that. So I don't know if Karthik would agree with that, but I'm hopeful that maybe if we uncork this one, people will step up enough.
Don, how would you advise people to bring patience into the steps we need to take to emerge from the crisis?
That's a very big question. It's the same as in safety. Funny, I'm noticing analogies to the safety world. We couldn't get momentum in safety without learning how to invite patients, families, and communities, not just to report to us on what's going on, but to help take the lead on this. It's really a shift of power. I think the same may be true here. And so, I'm the wrong color, the wrong age, and the wrong gender to be talking about racism. We need to really elevate the voices and power of people who have been not had voice and power and agency. And I think that's essential to this work. Plus, in safety, often it's the patients that come up with the best answers. They can tell us what to do if we'll listen. I'm pretty sure the same would be true with respect to this area of inequity, if finally people have the opportunity and the sense of power and possibility to speak up.
My last question has two parts also. One is, what else do you want to hold on to from the pandemic as a system change?
Oh.
And then personally, what do you want to hold on to?
This is on the positive side. I'm hoping I'm getting some applause from Nat Kendall-Taylor, but one is a speed and proper standardization. We have become much more diligent about studying the science and trying to bring the science to bear at a global level. And I want to take that home. I think if we could maintain that sense of tempo and commitment to fact that's emerged in the professional community anyway, I think it would really, really, really help. For me personally, I don't know. It's, I grew up in a really, really small town, and we all knew each other, and it wasn't always nice, but we knew each other. And there's that part of this COVID thing that to me, I find very potentially inspiring. So we're all in this together. My biggest fear right now is we're going to forget the global South, that we're going to fix it in the North and not realize we are equally responsible for what's happening in countries with $2 a day incomes. And that question will be called. But, we are a small town, aren't we? The planet.
We're learning that, I hope. Don, thank you so much for being here, for your work and all of your inspiration today and for many, many years. I'm going to toss it back to Barbara and Peter for some closing comments.
Great. So thank you. Thank you so much, everyone. This has been just really an exceptionally thought-provoking 2 hours. So on behalf of all of our risky business planning partners, I just want to thank each of the speakers for your exceptionally thoughtful remarks, the audience for some just amazingly provocative questions, and I realized we couldn't even get to most of those. And to Rob and Martha for their skillful moderation that helped pull it all together. We know we barely scratched the surface in the time we had, but we'll be continuing conversation on Twitter using the hashtag RiskyBiz21. It's on the slide. I'd also invite everyone to save the date for a full-day Risky Business Conference next April 7th at the JFK Library in Boston, which was where this conference was supposed to be in the fall before COVID struck. And at that point, we'll be able to explore these topics in even greater depth, and fingers crossed, have a chance to say hello to one another in person. So, Peter.
Yes, thank you, Barbara. We certainly have been missing the opportunities to connect and be together. But thank you, everybody, for attending this webinar. It's been so insightful and thought-provoking, and I hope it helps as you start to manage issues that arise within your institutions and within our societies as we move forward. I do want to finish by thanking a wonderful support team behind this webinar. Folks at Boston Children's Department of Education, Leslie, Allen, and co, just fantastic. Thank you. And the Betsy Lehman Society as well. Thank you so much, Michelle and Emmy. Thank you. Just brilliant. We really appreciate all that you have done for us. And with that, we will close. And I wish everybody all the best for the rest of their day. Thank you.